introduce myself. My name is Dr. Sarah Coll. I'm an orthopaedic surgeon based in Cairns in far north Queensland. And today I'm going to co-host with Yamal, who is the Cairns-based radiologist for Queensland Xray, the only Cairns-based radiologist for Queensland Xray, and has been here for how long?
2 years now.
2 years. Are
Yeah.
you planning on staying?
Yeah, that's the plan.
That's the plan. What do you like about Cairns?
I guess the bushwalks.
Yes.
Yeah.
The environment.
Yeah.
Yes. Very
Like the main
good.
attraction.
Is it really?
Yeah.
What's your favourite bushwalk? Hello.
There you go. Sorry.
Good. No, don't apologise. Yeah, me too. The
I like the arrow walks.
red arrow.
Yeah.
Oh, and
Well,
have you
all
done
of
the
them.
green?
I've done all of them.
Have you? I haven't had the guts to do the green yet. What's good about the green arrow? Why do I want to do that?
I don't know. I mean, it's long.
Oh, great. How long did it take you? Or how long do these walks take you?
I can't remember.
A couple of hours?
Yeah, like one time I did all of them
Yes.
back to back, and that took maybe an hour and a half.
Oh, okay. Okay. Do you need bug repellent?
No.
Do you need snake spray? No.
Maybe.
Okay.
Yeah.
So we talked about this on the phone beforehand. We talked about what we were going to talk about.
Yeah.
And we were going to talk about, we're going to focus on referrals and obviously referrals for orthopaedic conditions, because that's all I care about, because nothing else matters. And so the first one we were going to talk about would be shoulders. And I guess from my perspective as an orthopaedic surgeon, I do appreciate pre-consultation imaging. I'm still a fan of X-rays. I don't know what you think about that. And I'm also still a fan of ultrasound, but I understand its limitations. What are your thoughts about what's appropriate imaging for index shoulder presentations?
I think they all have their place.
Yep.
So it's sort of obviously a bit of a broad kind of question, but
Okay.
I think in the setting of acute trauma, X-rays
Yes.
are really helpful. It's quick to get.
Yes.
And we can actually answer a lot of questions like fracture,
Yes.
dislocations. And the other advantage with X-rays is that we could do dynamic kind of stress testing, like if there was
Yes.
a, ACJ,
Yeah.
ligament sort of injury that.
Yes.
So it's compared to say like static imaging,
Yes.
with like MRI and CT, where we,
Can't move the patient.
Yeah.
Yeah.
Put weight and kind
Yeah.
of see if we can make that.
Do you
So-
often see negative ACJ stress views? Do you see that? Because I never see a negative one for obvious reasons.
Well, so we usually do comparison moves with the
Yeah.
asymptomatic side.
Yeah.
So that's kind of, and then if they look similar, then I would call that normal or negative.
But at what proportion of your ACJ stress views would come back as normal?
Quite a bit. I would
Oh,
say.
really? Okay. Yeah. Because
yeah.
I only see the ones where they come back positive.
Yeah.
Okay.
I guess
And so
when they come to you, maybe
they've got
yeah.
a diagnosis. Yeah. So I guess what I'm saying there is, I guess what you're saying is if they've got, so you want an AC joint stress view if you can see a visible deformity.
Yes.
Yeah. So
Yeah.
without really a visible.
Or if there's clinical suspicion, I guess, then I would.
Yeah.
advocate for that. Like we wouldn't do it as a norm. If that's what you're. Yeah.
Oh, so what I'm thinking is, in order to drop down the number of normal views, then you want to change the referral indication, which I would imagine is if they had an obvious deformity.
Yes. Yeah.
But then you're also probably saying it needs to be acute. So they'd have to have some sort of, the patient would have to almost self-report the deformity.
Yeah.
And then I guess the best way to test for deformity is put a weight in their hand and see what happens. But because that's how they do the X-ray. But I just wonder if what they're looking for is those low grade ones, the grade 1 and grade 2, which are going to be harder to assess clinically.
Yeah.
So, okay. So I guess the indication for a stress view would be, I would think in most people you can almost see that visible mobility, when you're looking at the patient.
Yes.
Yeah.
Or
So
even, and I don't know if asymmetry helps clinical sense. Obviously, it means that you got to look at both shoulders.
Yeah, sure.
But and then deformity,
asymmetry, deformity, and also if you can get them to move it. And okay, so ACJ, stress views, acute injuries. You're talking about fractures. And you were just looking at an MRI scan of a greater tuberosity fracture.
Yes.
Was that visible on X-ray, that one?
It was.
It was. Yeah. Okay, great. So I guess my question there is, do you see a lot of undisplaced proximal humeral fractures?
I wouldn't say a lot.
Okay, good.
Yeah.
Okay, so you see a reasonable, but you do see undisplaced proximal humeral fractures?
Yes.
Yep. Okay, so it is possible that they could fall, have a bit of a sore shoulder, and unless you did an X-ray, you wouldn't know that they had a proximal humeral fracture.
Yeah.
So that's basically what you're saying.
Yeah.
Okay, so X-rays. The reason why I like an X-ray is because I get from here sort of all the way to here, so I get a little bit more. And sometimes I pick up, well, not so much because you pick them up, pick up tumours, but you guys pick them up first. And that's why I quite like an X-ray, because I'd never want to miss something.
Yeah.
But can you think of any other reasons why you'd want a shoulder X-ray? Trauma, fracture, tumour.
Yeah, tumour definitely.
Calcific tendonitis. There you go.
Yeah.
Do you decompress calcific tendonitis yourself with the? Do you do the?
Yeah.
Yeah, you're happy to do that. Barbotage.
Yeah.
Do you know what we're talking about? Do you know what we're talking about with decompressing calcification? So you can get acute calcific tendonitis of the shoulder. Have you seen that before?
Oh, decompression surgery.
No. We're talking about something different. You can get acute calcific tendonitis. Have you ever seen that?
On imaging.
No, on the ever seen a patient with an acute?
Not acute. No.
Okay. Have you ever seen it? No. Okay, it's horrendous. They come in. I've seen a PE teacher from down south. He came in, he was on a morphine infusion in the hospital that he was coming from. I made them unplug it and he drove up and he was like nearly crying. And he went, so he had acute calcific tendonitis. So he had a little blob of calcium in his supraspinatus. I don't have a good answer for what the etiology is. You haven't heard? No, it seems to be completely spontaneous. I've seen it in the hip once. I've seen it in the external rotators of the hip. But it predominantly affects the supraspinatus and they get a little chunk of calcium, like a cloud of calcium depositing. And it's agonizingly painful for about 3 days. If it's the left side, they present to the emergency department thinking they're having a heart attack. And so that's why you may not see them, because they come in at this acute presentation. And you can barbotage them, which is just basically putting in some local anesthetic and then a fairly large needle. And basically, if you put it in the hole, it comes out like toothpaste. So it decompresses itself up the tube. It's under so much pressure acutely. You look like you're getting distressed. And the patient on the end of the needle, the patient is just like, the relief is extraordinary. You know, you can't imagine. They just get fantastic pain relief from this process. It's a one-off. You don't do it very often. It comes back. It doesn't come back in most patients. But an acute calcific tendonitis can present a little bit like a trauma. You know, they think they've hurt themselves, or they think maybe I fell over yesterday and now today I've got this calcific tendonitis. Yeah, but that's good fun. Go on.
Something worth mentioning. Along that sort of calcific tendonitis, we do sometimes get referrals for barbotage for quite chronic kind of calcification. True. And we actually see calcification quite commonly, and it usually doesn't mean much, and it's certainly not indicated for barbotage. We can't really,
once it's solid.
So I've started kind of commenting not suitable for barbotage.
Yes,
we get a lot of
referrals just in case. I agree. I know what you mean, and certainly I've seen that before. You know, this is a chronic condition and therefore not suitable for barbotage. Hello. Come on in. See, now you don't have to feel bad about being late. Pull up a chair. We're up to.
Does no one else want cheese? Or do we do
oh,
this
please,
after?
no, cheese.
Oh, come in with cheese. Otherwise, it's just me.
Sorry, this is Katie Williamson.
We know each other well.
Thank you. And have you met our physiotherapist? So we've got Amy Stokes and David Alba, exercise physiologist.
Okay.
And Stephen from Queensland Xray.
Oh, yes, I met you at the Christmas party.
Katie is an extraordinary GP. So we're up to acute calcific tendonitis, and we're talking, okay, you might have an opinion about this. We're talking about the age of the calcification and the issues about how once the calcification is a little bit older, what happens is it's less like toothpaste and it becomes like a solid mass. And it usually sort of is a lot smaller. And if they've just got speckles of calcification, then there's not really much you can do about little specks. And there are people who do sort of seem to keep producing a little bit of calcification, but it's more just diffuse. So if you read an ultrasound report and an X-ray report that says calcification, you have to match it to the clinical presentation, or else you'll you have to match it to your clinical presentation, or you won't be able to help them. Is that it for shoulder X-rays? What was your question, Katie? When you finished your food, you can tell me. You can ask me your question because it was a good question. Yeah, you can do it now because it was a good question. But I've asked you when you've got your mouth full. Come and sit. You can come and sit. I promise you won't be on the screen.
I was just talking about shoulders and imaging in the GP setting, and I mean, us GPs probably see 99% of shoulder problems, leaving you the 1% that.
Yeah, we've just established that.
And I suppose we get to a point where you've got the history, say it's non-traumatic shoulder problem, or not major trauma, rather, not acute onset. You've done your shoulder examination. It suggests some rotator cuff tendonitis, maybe a bit of bursitis. The patients often come in, you say, oh, what are you here for today? Oh, I'm here for a referral for an ultrasound. And then you take history, you examine them, and you go, yeah, well, you don't need an ultrasound, you need physio. At what point, because I get a lot of registrars saying, I'm really worried I'm going to miss something, I'm going to miss a big tear, and then I'm going to get sued because I didn't image and refer sooner. So at what point is it the major trauma, the absence of major trauma that we should feel comforted by and just manage conservatively? Or is it chronicity?
Red flags.
Yeah, well, what are the red flags? Probably what I'm asking.
What are they?
Yeah.
Me. So night pain. So just
no, but for a red flag for a rotator cuff tear specifically, night pain, you reckon?
Oh well, if there's some cancer that could be.
Oh no, but red flags for rotator cuff tear specifically.
I guess
you know what I mean. Like, what's the?
Yeah, like for fracture and.
No, if the patient's sitting there in front of you with a rotator cuff tear, how do you detect that? How do you know that they've got it? That it's a rotator cuff tear?
Oh, well,
do you see
rotator cuff tear, like red flag for that itself?
Yeah.
Well, I suppose the question more so is it something that needs surgical repair? Because a lot of rotator cuff tears can be.
Yeah. So assess for surgical suitability. So you hear that? That's what they're because they'll physio exercise, they're happy to keep it as long as it's not suitable for surgical repair. Yeah, because that's your answer, really.
If it's kind of a partial tear, it may conservative management's the best option. If it's fully retracted.
But you're saying if there's no imaging.
If there's no imaging, so I mean, because you're not going to image every shoulder.
Yeah. No.
Yeah. So if they're not a fit candidate for surgery, or if they're not interested in surgery.
Yeah.
Or you know how you have that, there's a subtext to the conversation where you're looking at them and you're going, this person's not going to come to surgical treatment.
Yeah.
Well, then you're not going to gain much more. Like you said, the physiotherapist and the exercise physiologist, they're the people that are going to know what to do with them.
Yeah.
Yeah. I think that's a good answer.
Full rupture, they'll have considerably less active range of motion.
Yeah.
And it'll generally be a lot less painful because there's not any tension on it. Because it's not partially torn. But in terms of being able to work out if it's suitable for surgery, it's probably something that's...
the GPs know that. GPs are good at that.
I was going to say it's not even in an EP scope.
No.
So physio scope, like if I had an acute rotator cuff tear that they came in and I said, I just fell over and hurt my shoulder right now, I'd say, well, this isn't even something that I can assess.
Yeah, I'd probably scan that because it's an acute injury. You know?
Yeah.
The test I like is the power in this range.
Yeah.
And I find that that's a better way of detecting a acute, chronic, 3-month-old sort of tear. They come in and they're like, oh no, I feel better now. And then you go, well, can you do that? And they're like, no, I'm weak. Like I go to do something at work and I'm weak.
Yeah.
That I find that, like you say, like they don't always come in with a flail arm. They often come in with good range of motion, and the physio can often get them good range of motion. Yeah. The question then
when
is,
they start proving like we can see them for a while, and if they don't make any gains, that's when like something else is going on.
Yeah. So how long do you give them?
I usually try and see them at least 3 times.
Yeah.
But if you can usually tell like the second time if that pain's not getting any better, there's something else going on. But like especially where we are, like it can be quite hard to get into a doctor. So I don't know what it's like down here, but it's quite difficult. So sometimes they come to us first and they try and gain some little bit more understanding what's going on.
And I would say that though, go to see the physio and it's not getting much better in a few weeks.
Yeah.
Come back and
a couple of sessions.
Chronic or acute?
Wow.
Chronic, okay, yeah. Because chronic, they may not get better in a few sessions either.
No, that's right.
Could be
So
unrelated
if it's chronic,
to,
it's longer.
could be unrelated to a rupture, could be.
But it's interesting that
and a host of other things.
With all their experience, they still don't want to pick it clinically on the first consult. They still want a couple of consults, which I think perhaps GPs are kind of trying to diagnose it all on the first time you ever meet someone. You know, because I agree, you have to sort of build that relationship to be able to tell if what their expectations are and of their own body and why they want, you know, and so a surgical indication is someone who's got a functional deficit. So you don't want to operate on people who don't have a functional loss. Yeah. So they have to demonstrate to you that they have a functional loss that they can't rectify. So that's why they can't pick it first go. That's what they're struggling with. You were going to try and say something before about rotator cuff and ultrasound.
I sort of forgot. So I guess the only other thing with the wait and watch approach, I mean, if they're not a surgical candidate, that's easy. But if they are, I mean, and I don't know the answer for this, but you know, like with time, if there is a tear, there's a risk that the muscle belly can get like fatty
atrophy.
So you don't necessarily, you know, want to leave it too long to the point where it's gotten fatty replaced because
how long does that take?
I don't know. That's why I said I don't know the answer to that. But, yeah.
So what he's talking about is gradually over time, when the tendon retracts off the bone, the muscle gets replaced with fat, and he can tell us how much fat has infiltrated the muscle, and that based on I'm not very good at judging it, but based on the amount of fatty atrophy, it will tell you when you pull the tendon back to the bone whether or not the muscle will be able to regenerate. And so once it's all turned to fat, then it's very unlikely. But also what happens in that process is the tendon stump becomes really thick and rubbery and quite hard, and you have to pull really hard on it. So if it's a chronic tear, you have to pull quite hard on the tissue, and it doesn't have much plasticity and it won't flop back into the hole. So you can have a rotator cuff repair on someone where the tendon just goes flop and sits straight back down where it was, or you can have a rotator cuff repair where you kind of reefed it across. And so that's why you're getting different, particularly for the physios. I send, they've got a rotator cuff repair, but you have no idea what the tissue integrity is like. And so that's why you can get different responses, stiffness, range of motion, power and stuff afterwards. But you're right, you don't want to leave it until they get fatty atrophy, because you really, and I would think, if I had to guess, I would think that would take 3 to 6 months from the acute injury. The trouble is, I think you're often dealing with something where you really don't know when the injury date was.
Yeah. or it could be like a multi-hit trauma, like where they get a partial and then another maybe partial and then complete, you know, and we don't know when the initial trauma was.
Sometimes I see patients who've had a sequential series of ultrasounds over the last decade, and you know, you can see the partial becomes a bigger, partial becomes a full. Yeah, sometimes you see the series. Do you? Yeah. So
tricky.
So that's a bit of a circuitous answer to your question, but does it help? Yeah. I think yes, leaning on the physios is helpful because they've got that opportunity to get that feel for what you're dealing with.
And I suppose, what would imaging achieve if it's not a full rupture?
Well, that's the question that's with GPs a lot of the time, you know, that we're tasked with not over investigating. And so, and that's it's a difficult position for a lot of the registrars to be in too, because they don't know. They don't have the experience to go, that's going to get better with physio. And the time constraints to assess comprehensively psychosocial, what the mechanism is. Has there been a re-aggravating factor? Because if someone presents with chronic shoulder issue
with severe pain and no mechanism that would explain a ruptured tendon, it wouldn't be the first thing that you jump to. And so you wouldn't even consider imaging unless there were the red flags, because then you're looking for something other than a rotator cuff tear, something more sinister, I suppose. And then, but yeah, my first port of call would be, as an EP, would be referred to a physio for diagnosis.
Interesting.
And sometimes, doing imaging, I guess, when maybe it wasn't indicated, can kind of, I've seen where it kind of drives down the wrong path, where
you start chasing.
And there might be like a cervical radiculopathy, for example, and but we did an ultrasound and say there was like a small tear, and now the patient thinks that's the reason for the pain, and we do all these injections not working, like what's going on,
true.
So but I don't know.
No, that's true. That's terribly frustrating when you find bursitis and then there's a claim or a work cover claim around the bursitis, and then it becomes obvious that it was actually a cervical injury and that they've got nerve root problems. And then you're right, sort of trying to dial that all back again and say, no, actually it was your neck all along. It's really, it's hard for the patient to grasp that.
And unless you've got someone involved in the care team that has the time to explain the imaging findings, that's the big risk you run. So is there time? So
they hold on to the conclusion.
Yes, I do. I find the radiologist word is gold. I've just spent 45 minutes explaining that I disagree with the radiologist, but the report says that the patient's got a problem. Once you write it, it's true. Forever.
It's the meaning they make of it.
Absolutely. They carry it with them. They really they identify with your diagnosis. It's really interesting.
And it's not uncommon for a lot of us to call a little bit of bursitis or mild supraspinatus tendinosis, because because it is subjective, and there's sort of like, when do you call it? And there's no exact measurement to say, well, if you have this much of fluid, then we'll call it bursitis. So when we see like a little bit of thickening, we use words like minimal or mild to kind of play it down. And so unless it's like slam dunk normal, most people would say a little bit of bursitis, because that gives you the sort of wriggle space to then kind of go, clinically, is it important or not? Instead of saying completely normal, because
Well, it would be hard to say this is a perfectly normal shoulder. It's like saying someone's got a perfectly normal back.
Well, it's almost kind of like you would say it's perfectly normal based on normative imaging findings, and that's kind of
normal for age, normal for activity.
That's kind of where it's really great. Is at what point can you say, well, look, that's got minor bursitis, a little bit of calcification, and some wear and tear. I shouldn't say those words. That's what you will get when you scan all the people in their 30s. Or
absolutely.
40s.
Absolutely.
And then we comment on something that seems to be associated with previous mechanism of injury or something like that. It seems to kind of match up well with the pain classification and presentation.
So how do you like to see a shoulder MRI scan referral? What do you like on the referral form? MRI right shoulder.
Please assess.
You don't have to treat. I get please assess and treat. You can have just please assess.
I guess the clinical question, like if you have a clinical suspicion, and especially things like impingement, which is not really something we can diagnose on a static image. So if you suspect clinically that that there's subacromial impingement, like I like to see that. It can be helpful. In terms of if you see something mild, but there's clinical suspicions, then we can say like, okay, well that fits.
Sure.
And then also just where, like, if the patient's got pain, where the pain is will be helpful.
What do you mean?
Anterior.
Okay.
Example,
anterior or posterior?
Anterior,
that's
posterior, or generalized, or like localized. So some clinicians would say localized to the ACJ, or
yes,
because it's not uncommon where like ACJ after about 30s, like most people will have a little bit of degenerative change.
Absolutely.
And then certainly after 40s, we see it all the time. It's
all
just
the
one
time.
of those joints that, you know, get
why?
worn out. I don't know.
I don't have a good answer for why most people have ACJ degeneration.
It's so common. Like you do PET scans, pretty much everyone will have a bit of hotspot there. Like everyone.
Like it sounds like a really dud joint. Like it's more than base of thumb.
Yeah.
Yeah, and I think base of thumb is most common.
Yeah.
And AC joint, it's just always there. Yeah.
So you know, like if the patient's asymptomatic, we can really play it down in the report so that you know. But then it's like,
because if you say they've got a degenerative, if you say they've got a degenerative joint, then the caseworker reads it, and the caseworker says, "Oh, well, therefore it's pre-existing," and you're like, "Well, it's the AC joint. It's absolutely nothing to do with you know where their shoulder problem is."
Yeah. But then, like if the patient's focally tender or symptomatic in that area, we can put more significance.
And what about artifact? Don't you get artifact over the AC joint? I sometimes see that, you know, this might be arthritis, but it could be artifact because it's subcutaneous. No, I thought I'd seen that on a report. Okay, not one of yours.
Doesn't sound like something I'd say.
Clearly. I'll stop talking about that then. What about labral tears? I know I request them all the time. Do you ever look for them? What are your thoughts about labral tears?
Yeah, I think so. That's another one that's really helpful if that's on the request form. Like if you're clinically, you know, suspecting, or even if you say like instability of the shoulder, that's the useful thing to know.
Yeah.
Because then, you know, we take an extra hard look at the labrum because it's not difficult or it's not unusual to miss like a subtle labral tear. Like if it's, you know, if it's like a displaced labral tear, then, you know, anyone should be able to pick that. But sometimes you have like subtle labral tears where it's not really displaced and you could overlook it. But if someone had instability history, then we'd make sure that we take a really close look through that area. So that's a useful thing to.
I think that's very.
You're talking about MRI.
MRI,
not ultrasound.
No.
And what's the most common place for a shoulder labral tear? Like, I mean, imagine with high impact, obviously you're going to get a posterior or anterior depending on the mechanism. But like the hip, can you get these funny labral tears that just seem to, they didn't even know how they did it? Yeah.
So that's a very controversial question, and if you are welcome to come to a shoulder and elbow society meeting, and we argue about that for about 3 or 4 hours at a time. So my answer to the question, I'm a big fan of slap tears. I think they do present clinically. So that's the superior part of the labrum. The classic shoulder dislocation is antero-inferior. So if you look at it like a clock, that's usually, you know, down the bottom corner, and that can, you know, they can be little tiny tears, or they can be big chunks, and they can even have fractures associated with them. I believe that the posterior labral tear is pre-arthritic. So once they start getting a posterior labral tear, they are very close to not being able to swing a hammer anymore. You know, so I can see the lights on at the end of their career. So I'm very wary about posterior labral tears. And so there's anterior, anterosuperior, which is like the woman that's might have had a bit of a stumble, but not massive trauma. It's classically fall on the flexed arm. And then she's just got achy, clicky instability. Just I see a lot of, they go to load it and they can't, and then they don't. And then they get deconditioned. So that's how I see the slap tear, but then the antero-inferior is your classic, and then posterior, I think, is pre-arthritic. And there's, but like I say, we could talk about it for 3, 4, 5 hours. Have a great time.
I agree with you. Like I see like a lot of people who have posterior labral tears, they end up getting OA or already have features of OA.
Starting, yeah.
It must. Good. I think they have a lot of posterior instability, so it's compared to say like anterior-inferior, where depending on if it's a small tear, there might not be as much instability. But yeah, definitely.
So I think sort of that, like the anterior one, it kind of fractures out, and then they're very careful at keeping their arm in the right position. I tried to operate on a guy's hand yesterday, and he wouldn't put his arm out because he knew he was so unstable. He didn't want to put his arm on the table. So they know how to keep it in, whereas with posterior, it kind of just sort of slides out all the time. So when they're loading it all the time, it's kind of flicking in and out just a little bit, and they don't sort of notice that instability. They just wear it out.
And there's not as much, I guess, dynamic stabilizing support as well from the cuff. Like you have the subscap, which would be the opposing force to stop it from, as opposed to anteroinferior, where you have a significant portion of the cuff, if it's intact, which should also help to not allow it to kind of fall out if you have the infra.
Okay, any questions? So have we done shoulder X-ray, ultrasound, and MRI scan? Anything else you want to know? Anything else you want to talk about as far as referrals go?
I guess in terms of indications for using ultrasound versus MRI, like labral tear, for example, it's not really a structure that we could look at on an ultrasound or X-ray. But cuff tear is pretty good. Ultrasound's pretty good. We can't really comment very well on the actual muscle belly, like fatty atrophy. We can get a rough idea if we look properly. But MR is good for that. But that's a secondary thing. So as far as tears go, ultrasound's quite good. Like I don't think.
What about subcutaneous fat?
Does that affect your image?
Yep.
Not really. It's more pain we find. So ultrasound, because it's a dynamic assessment, and we try and range the patient to get a good look. If they're in so much pain, and the classic one is like adhesive capsulitis.
Yeah, I was going to say we haven't talked about that.
Yeah, and in those scenarios, they're not very good ultrasound candidates. Like we'll have a look, but it's hard for us to look at the foot plate properly, and because they can't externally rotate and internally rotate and. Yeah, so
but the
it doesn't mean that you wouldn't ask for an ultrasound, but it means that it might be not as good quality.
And the diagnostic test for adhesive capsulitis?
MR. Yeah, definitely MR. Yeah, people try and measure like the inferior glenohumeral ligament on ultrasound and the joint capsule. Like I don't even.
You wouldn't be able to.
I think people just make it up. Yeah, we can have a look. Well, I think so. Like I don't think objectively. I mean, we can see it, but can't really objectively comment on it.
Measure it.
Yeah.
You don't feel like you get a measurement of the thickness.
Yeah. I don't think we get accurate reading. Yeah.
Okay, that's good to know. So once it comes back with we couldn't do the ultrasound, then I know I'm looking at adhesive capsulitis, or so, like you say, someone in pain. I think with his incredibly expensive ultrasound, he's got a reasonable chance of seeing, beyond the subcutaneous tissue.
Yeah, haven't really had that as been an issue in the shoulder. Yeah, hip different, like there could be more fat in that area, and obviously other organs, but shoulder usually okay. Yeah.
So adhesive capsulitis, it's clinical diagnosis. That as long as the patient's relaxed and is allowing you to move them, it just feels clunk clunk. You can with a rip roaring one, and they're always 50-year-old women, and they always cry by the time they see me because they've been trying so hard to do their physiotherapy. They've taken all the medications under the sun, and their ultrasound was normal, because their rotator cuff is actually normal, and their X-ray is normal because they don't have osteoarthritis. And then they finally come and see me and say, "You've got a frozen shoulder," and because they've got an answer. But the answer I also give them when they've got a frozen shoulder is your shoulder is normal. You have a normal shoulder joint. It's healthy. You've got a healthy rotator cuff. You've got a healthy joint. When this process is over, you will have a normal shoulder again. Once the process has run its course. So it's good news and bad news. And then I do also tell them that in 12 months' time, they might get it on the other side. And they cry again. It's a very sad consultation. But then they're armed with the knowledge. And sometimes they'll come back and say, "I reckon I'm getting it on this side. Can you tell me if I am?" And then I say, then they've got a strategy. They know how they're going to deal with it. They have a preferred provider or treatment plan, treatment strategies, and then they're good to go. you want to move on to the knee? Sure. Knee X-rays. What are they? Oh, what about that? Haven't you got a fabulous standing EOS system? Tell us all about that.
Yeah, I mean, so EOS is really good to look at alignment.
Yes, good.
And we can do like just lower limbs. We can do whole spine or whole body.
Yes.
And the advantage of EOS is it's lower radiation than doing multiple X-rays. Of the same region. So say you wanted to do an alignment, we used to have to do like long leg X-rays.
Yeah.
And that's a higher radiation.
Okay.
The reason for that is with EOS, there's no point source where the X-ray kind of comes from one spot and then it diverges.
Yeah.
Because that causes more radiation. Because we need to put a bigger dose
at
to
the
get
starting
good quality images. Because the X-rays are sort of, because it's from a point source, it causes what's called scatter.
Yeah.
And that causes the image to be blurry. So we need to put extra juice to get a nice picture. But with EOS, it kind of follows from top to bottom. So it's not like a single point X-ray. Like there's X-rays that kind of go all the way down.
Yeah.
Which means we can use a lower dose and still get nice pictures. Yeah. So that's the main advantage. So we use it a lot on children, teenagers, with scoliosis, because they get like multiple X-rays.
We don't have to ask for that though. If we order, say for example, if we ordered a spine in an adolescent, you just know to do the EOS because of that.
Yeah, so we often like call your clinic and say we recommend EOS because of lower dose, and that's how we usually wouldn't override you, but if we think that there's a better option, we'll
so that's a no. So he won't do EOS until you actually write EOS on the form.
It's just like a Medicare and legal kind of thing.
Yeah.
Where we can't just like if you request a different.
So they stand inside a booth. Is that how this works?
We can show you.
Yeah. We'll do that at the end if that's okay. So they stand.
An MRI.
Yeah.
It's unfortunately in use to
it's always running. So the EOS machine, they can stand in it. Can they move in it?
No, so we advise the patient on how to position themselves.
Yeah.
And then once they're in, then they can't move.
Yeah.
Until we take the picture, because we don't want obviously motion artifacts.
Okay. Yeah. So it's not a mobile thing. They just stand.
Yeah. So the main advantage is the dose and being able to take large field of view images in one hit.
Can physiotherapists order EOS? Do you know? Oh, there you go. There's the answer to that. So you can stand them up. So, you can see, oh, hold on, their left leg is like, a centimetre shorter, and now they've got a, positional scoliosis. Well, that kind of explains it. I mean, I know you guys have got X-ray vision. You actually look properly. But how you're always thinking about that whole alignment situation. I just wonder if that might be a useful modality for you.
Is there an extra cost with the physio? If they refer?
Oh, there you go.
I don't believe at this point.
I
think Allied Health, we are still bulkily because it's brand shiny new. We're trying to keep it accessible across Queensland X-ray.
Yeah.
Double check that, but I'm pretty sure.
Yeah, I'm pretty sure it's rebatable.
Yeah, because I see so many chiros, physios. Yeah, absolutely.
Yeah, so it's really helpful. Like say there's a leg length difference, and it will show like if there's a pelvic tilt and what the actual difference in the leg length is, rather than doing like X-rays where it's hard.
Especially if they're lying down, because this is with them actually standing up.
Yeah.
See, so that's much more clinically relevant. Once they lie down, you could see anything.
Yeah.
As far as pelvic tilt and things go.
Yeah. And it's really
much better.
Spine as well.
Yeah. Oh, and I'm just thinking about things like lumbar lordosis, when the lordosis is just huge, and you're just thinking, what is that? Is that muscular? Is that purely muscular, or is there actually a structural component? It would be handy.
Yeah. And quite a common issue, more in the elderly, is they start losing their sagittal balance as well.
Yeah.
So they will they lose the lordosis in the lower lumbar region, and then they got to compensate with pelvic retroversion. And then if that compensation is still not enough, they'll start moving further and further forward. So their center of gravity is further anterior, and then which I'm sure as we could, like if it's really bad, you can see it clinically, but the more mild ones sort of easy to.
But it's quite striking when you see it on the EIs.
Yeah.
Because it becomes, you can sort of see through the whole sort of confounding factors of clothes and posture and not posture, clothes and their body shape. You know, suddenly you see this is their spine and this is what they're working with. I quite often see people with terrible neck pain who are really struggling, but they've got a terrible kyphosis, and trying to explain to them the reason why you have neck pain is because your kyphosis is just awful. They really struggle to get that concept. But I mean, if I could show them the kyphosis and the, like you said, the flat back and then the flexed hips, then I would imagine that'd be easier to get that message across. So EIs, and it's useful for leg length discrepancy for planning knee replacements and things like that. You know, just making sure that you end up with two legs the same length after you've done the second side. You know, you want to make sure that you take them both out at the same length. And hip replacements, it's nice to see the pelvic tilt. I think they're accepting that, you know, there's a component in a hip replacement, there's a component of a stiff lumbar spine and then pelvic tilt and where you want to put the hip, you know, the center of rotation, we can put it wherever you want. And so you want to put it where it's going to leave them with, you know, their head over their feet and still having, you know, 90 degrees of flexion such that they don't suddenly dislocate out. Knee x-rays. Indication for knee x-rays, trauma, same as before, don't get calcification.
Trauma for sure.
Proximal fibular fracture, sometimes they're hard to pick, you know, a little bit of a sprain.
Yeah, they're hard to pick. The tibial plateau fractures are quite hard to pick if they're undisplaced. So that's a classic one where, you know, you can have quite significant trauma, but on the X-ray not look very impressive.
Yes.
So tibial plateau is always I mean, obviously they'll have a big like hemarthrosis, so that would give away. But the actual fracture can be hard to pick if it's not displaced or the article surface is not collapsed. The more high-end tibial plateau fractures obviously will show up, like the Schatzker 4 and 5.
Yeah, absolutely.
But yeah, X-ray is definitely good for acute trauma.
Loose bodies.
It's also good for loose bodies, alignment, kind of similar to EOS. So you know, we can look at alignment. What was I going to say? Also, position of the patella is really easy to see on X-ray. So patella alta or patella bhaja is good to see on X-ray.
What about the sunrise view?
Yeah, that's
sunrise.
Skyline.
Yeah. There you go.
So we use that to look at patella, position of the patella and see if there's like maltracking. So that's, I mean, if you're clinically suspecting patella maltracking, it will be something useful to put on the request form because we don't necessarily always perform a skyline. So that's in
women with anterior knee pain. Skyline views can be very helpful.
Yeah.
Ultrasound of the knee.
Yeah, so ultrasound of the knee actually has quite limited indications really, because we're very limited by what we can see. Like all the internal structures of the knee we can't really see on ultrasound. So we can't really see the cruciate ligaments. We can't see the menisci. If they're extruding, we can see that the meniscus is extruding, but we can't really say much more about it. More than that, we can't really comment on tears. So the only useful things with an ultrasound is Baker's cyst, definitely, if you think.
But I hate you finding a Baker's cyst because then they want it removed.
Yeah.
That can be annoying because go on. But it does tell you that there's likely intra-articular pathology. Yes, handy. Go on. Yeah, Baker's cyst. Yeah.
Yeah. So Baker's cyst, and then pes anserinus bursitis. You can see the pes anserinus pretty well on ultrasound. So pes anserinus bursitis, if you think clinically. And then pre-patella bursitis is the other thing because it's nice and superficial. So ultrasound we can have a good look. And then anything with the extensor mechanism, like we can have a look at the soft tissue structure, so the quadriceps and the patella. If there's anything significant going on with that, we can see on ultrasound as well because it's superficial. But but anything internal, you know, like
CT?
CT for acute trauma, if you
What
wanted
about
to.
for looking at menisci?
I wouldn't. No, you can't really see tears.
Sounds like an MRI scan, hey?
Yeah. So knee like internal structures, MRI is really the only useful tool.
Yeah. It sounds like that's much more limited, isn't it? Whereas shoulder, at least we've got a bit of an answer. There you go. There you go. That was me.
But yeah. So I don't think there's anything else.
I mean, do you ever comment on the menisci or the ACL in a CT scan?
No, not menisci. ACL, like if it's like really ruptured, we'll be able to see it on the CT.
Yeah.
But not the menisci. No,
you're
can't
pretty much
see
big
that.
no. What do patients want? Do patients come in asking for an MRI scan?
Their knee. Sometimes, yeah.
That's the impression I'm getting from the referrals. Is that they'll come in wanting one?
But I mean, sometimes it is warranted because they've already seen physio. And they'll say, my physio told me.
The physio said I want an MRI scan. Yeah. I see that a lot.
Which is, you know, it's reasonable if they've had a trial of conservative management and then they've got signs of internal derangement of some sort. Then
you want to jump onto an MRI scan.
Billing shouldn't dictate as well, but GPs can refer for MRI needs for patients under 15.
Under 15, yeah.
50,
Under 50, 50.
Yeah, in Medicare in Australia. Acute trauma, any criteria, you put it on referral and they're bulk billed. As a GP, sorry.
Right, why on earth do they keep asking me?
As soon as you turn 50 in one day, that's when you get them.
50 in one day.
And what are the other indications, like clinical suspicion of meniscal?
Anything meniscal, ACJ.
Yeah.
ECJ.
Sorry. So anything, anything in the joints.
ACL. Yeah.
That's what we teach the girls to look for. It's you put an acute trauma on there, and it's every day of the week going to be covered. Even work cover won't look twice at that.
Right.
I think you've got to write query internal derangement.
Internal derangement.
And then if you offer more, which I generally do, like I'll say a positive Thessaly test or something like that.
Spoiling us.
A positive what test?
A Thessaly test.
What's a Thessaly test?
That's a test for meniscal tear.
Oh,
so
McMurray's.
Well, I do both.
What's the difference between a Thessaly and a McMurray?
You get them to stand up.
Weight bearing.
Weight there with flexion, so on the affected knee,
and then
so support them, and then you get them to twist.
Okay. I do that, but I don't hold their hand. Just make them do it themselves.
Oh my god, same.
They're standing next to the desk. If it hurts, they can grab on.
So it's got quite a good sensitivity and specificity.
Yeah, I know. I do it all the time. Yeah. Okay, Thessaly. Now I know I can write it in the chart. I'd like to learn how to spell it. Okay, yeah, so positive Thessaly test, right?
So if you write something like that, but I think Medicare is just internal derangement.
Is enough. Okay, well, that is extremely helpful. Yeah, okay.
It has to be acute for GPs.
Yeah.
We have to say, so if you put chronic on there, something like that, and they haven't had a recent injury, we are really trepid about it because they are very much an acute. It's the first word on the description for the MRI item number.
Okay, and so the process appears to be see the patient, send them to the physio sends them back and says, no good. MRI, acute. Okay, so I haven't got very much time left. Go on, what are you going to say?
The other thing is obviously commenting on cartilage again, MR.
Yes. Yeah, you've got no chance otherwise. Now, I've heard about a 10 Tesla MRI scan where you can see the cartilage cells. Is that right? So when are we getting our 10 Tesla MRI scan?
So they're not used in clinical practice. And it's actually quite uncomfortable going into one.
Why?
So a lot of people get nauseous and they vomit because because basically all your hydrogen atoms in your brain kind of gets aligned in one plane.
Sure.
And I mean, that must be pretty, I don't know what that does, but but I know, like, we used to keep like a bucket, you know, like it's not good.
To crank up the 10 Tesla machines.
Yeah.
Wow. So you've seen a machine?
No. Like, I've read about it and I've seen videos about it. Yeah.
Okay. Wow.
So,
wow.
yeah.
Okay. Well, that's
Lots of
pretty.
patients comment they have sensations now 3 Teslas.
Yeah. Right. Okay. So they start getting a bit irritable. Okay. That's fascinating. I didn't realize that was
It
true.
might just be me.
Hey.
It might just be me.
Any questions? It's your last minute chance to talk to a radiologist. We could talk about hands. We could talk about wrists and MRI scans.
Yeah.
Wrist X-rays. We could talk about wrist X-rays.
Yeah. So wrist X-rays are quite useful.
Yeah.
Yeah,
Agreed.
really useful. It's useful for OA. It's also useful for inflammatory arthritis. You know, like
you'll see the
rheumatoid.
cystic change.
Yeah. So we can really get a good large field of view.
True.
Look to see the pattern of joint involvement.
Yeah.
Because certain, inflammatory arthritis has like certain joints that they prefer to involve. So, psoriasis versus rheumatoid or CPPD or gout, like they all have. So X-rays are really useful. Like even if there was an MR, like we often ask for an X-ray as well if it wasn't requested, because the X-ray kind of adds that extra bit of.
Really?
Yeah, because erosions are easier to see on X-ray. And then obviously acute trauma is pretty good. Looking for fractures. The things that X-ray and ultrasound are not good for are ligamentous structures. So triangular fibercartilage, you can't really comment.
Not unless the ulna is like over here.
Yeah, exactly. Yeah.
Which it sometimes is. Go on.
Yeah.
And then what about and I use a little bit of I get them to flex under load and I get them to like pull really hard. Sometimes that can make the ligaments kind of give a bit, and so the bones move around a bit, so you can kind of get them in radial and ulnar deviation. Sometimes they can get a shot and get them to do a really tight clench. You have to coach them that it's going to hurt when they do it, because if they just do one that doesn't hurt, then they're not actually moving the bones. Like the painful thing is the fact that the bones start moving around under load. So you've got to actually coach them that they want to squeeze tight, because otherwise they'll be too frightened to do it. And suddenly you'll see something pull apart.
But we do a clenched fist X-ray if you're worried about like scapholunate ligament disruption, and you see like on the normal X-ray it looks fine, and you do a clenched fist and they kind of the scaphoid kind of moves away from the lunate. And you'd only see that on a
clenched fist.
Yeah.
But they have to actually clench. Like I think there's a lot of kind of it's got to, like you can see the fingers are bent, but until they try, it makes a big difference. But then also you could do 4D scanning to look for the ligamentous. So you can if you've got a small field, 16 centimeters, if you've got a small field, they can actually move their joint. You can see if the bones move normally. Yeah, so it's 4D because it's in 3-dimensional and then in real time. So that's pretty good for wrists. And then ultrasound. I use ultrasound, but to me, when we do an ultrasound, it's carpal tunnel, or is it de Quervain's, or is it the extensor tendons? It's always it's a narrow scope of investigation generally. For a wrist.
They're pretty good, so tendons, tendon sheets,
trigger finger,
pulleys, they're pretty okay.
Yep.
Looking at the thickening of the pulleys.
Gyptrons?
Yep.
You happy with that?
Yeah,
good.
Because it's very, very superficial. And it's actually more useful than an
MRI.
The reason is if we see like a little nodule kind of thing, and we're trying to see if it's coming from the tendon sheet or the palmar aponeurosis.
Yes.
If you move it and the structure doesn't move with the sheath, then it must be from the aponeurosis. So that's where we go like, well, that's a diffusions contracture and not a tendon ganglion, like a tendon sheath ganglion. Because they literally sit on top of each other, so you can't really necessarily say with confidence on an MR.
Yeah.
But that's it's an uncommon thing. But if that was the clinical question, then ultrasound is a better tool to use.
Yeah, ultrasound saved me today. He had a lump, just a small lump in the middle of his palm, and I was 100% confidence it was Dupotrons because it had that thickened callus skin, but actually it was a ganglion with callus over the top.
Right.
And because I had the ultrasound, it was clearly cystic.
Yeah.
And Dupotron's never going to be cystic.
Yeah.
So saved me because I was about to coach him on the whole Dupotron story and tell him he didn't want an operation until it got worse.
Yeah.
But I was able to take out his ganglion because it was just a ganglion with callus. Yeah. So that was very handy. And so wrist, what have we done? X-ray, CT. I agree with the arthritis.
The other thing with ultrasound, again, like because it's a more real-time dynamic imaging modality, if you worried about triggering, that's another good thing with ultrasound because we can, like on MRI, we can say, okay, there's tenosynovitis, like this thickening of the tendon sheath, but we can't necessarily say if there's active triggering. But on ultrasound, we can get the patient to move their finger and it might lock at the time, but we can actually see bunching of the sheath and kind of getting trapped. So ultrasound's good for that.
Agreed.
Yeah.
What about carpal tunnel?
Ultrasound's good. Yeah. You don't like it?
No. Clinical assessment for carpal tunnel is king.
Sure.
It's definitely king.
Yeah.
And then nerve conduction studies and ultrasound are useful,
but
they are increasingly required by insurance companies and Queensland Health and all those sort of things. But I would never say they don't have carpal tunnel if they have a negative ultrasound. Is that fair? Yeah. So you can prove it, but you can't definitely exclude it, I think.
Yeah, no, I agree.
Yeah.
Because the main thing that we can comment on imaging is like if the nerve is focally thickened as it passes through the carpal tunnel.
Yeah.
But the patient might have irritation of the nerve and not necessarily have significant swelling of the nerve. So that's why we can't, like if it's negative, they may still have, irritation of the nerve.
Yeah.
It just means that they don't at least structurally have a significant neuropathy that we could demonstrate.
Yes.
But
structurally. Yes. Yeah. You haven't got the actual size of the nerve.
Yeah.
Dead on 6:30, so you're off the hook. Thank you very much.
Okay.
Thank you, everyone.